بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيدنا وحبيبنا ونبينا محمد. So because there was a lot of confusion in the topic of asymmetry, we decided to continue discussion in the same subjects, and we said that there are wide variations in breast size, parenchymal pattern. However, the breasts have fairly symmetric internal structures with more or less similar density and architecture seen at mammography to degree that there is some mirror each others. However, because of different positioning and compressions might result in some asymmetry. Which is relatively frequently seen in mammographic screening as well as diagnostic. And we said in the past, they typically consider it as a sign of malignancy. However, with improvement in technical aspects and the current high resolution images, mammogram the radiologist can differentiate benign from malignant based on mammographic images, and now most of asymmetries are considered as benign. Okay. We're going to have different examples. Okay, so we could fulfill the learning objectives. As we mentioned last time, we'd like to understand mammographic definition of asymmetry as described in Barat's, know how to differentiate asymmetry from mass, understand classifications of asymmetry according to Barat's 5 editions, discuss a practical workup of asymmetric mammographic findings and identify the causes of each type of asymmetry, understand the positive predictive value of malignancy of different type of mammographic asymmetries, understand management of different types of mammographic asymmetries, and recognize the advantages of supplementary mammographic views and other modalities for evaluation of asymmetric mammographic findings. And we said that mammographic lexicons is strongly recommended, and the mammographic lexicon abnormalities include masses, asymmetries, calcifications, architectural distortions, lymph node intramammary, skin lesions, solitary ducts, and associated features, as well as location of the lesions. And what is the definitions of asymmetries as described before? We said, any volunteer?
It's a description for a unilateral fibroglandular density that is seen in one or more mammographic projection. And this does not meet the criteria for a mass.
Okay, yes. So we said it's a spectrum of mammographic findings representing a unilateral deposits of fibroglandular tissue that has no mirror image on the opposite sides and is not full conforming or fulfilling the criteria of a radiodense mass, and is seen as a discrete area of increased tissue density. Okay, on one side, as we said, not mirror image, the opposite one, and completely lacking borders and conspicuity of a true mass, as could be seen in one side or one projection, in one projection, which again is the criteria for definition of the mass. And when it is seen in two projections, also lacking the convex border of the mass, appear as planar with a concave outward borders, and could not describe by using shapes, and as we mentioned, lacking the convexity of conforming the mass, and usually seen with interspersed fat within the lesions, as while the mass it appears dense at the center rather than at periphery. And previously I brought this example again because it was confusing for us, but it is focal asymmetry, but more or less similar to a mass, but it is not having the conspicuity, the typical conspicuity of the mass. Okay, compare with the mass here in the other examples, you see, and this again, this is a mass here, while this is a focal asymmetry. Look for the interspersed fat seen within the focal asymmetry. And if you look here, this is look like a mass. It has a convex border. It has a conspicuity of a mass. However, I could not appreciate it in the other CC view. So I have to report it as asymmetry until I could appreciate it. We could confirm full criteria for the mass, which include visualization in two orthogonal views. The spot compression confirm the appearance of a mass, okay, and ultrasound the same, confirm there is a mass, okay, circumscribed mass, but I cannot say from the mammography standard view, this is a mass. I will report it at the beginning as a focal, as asymmetry, since it is seen in only one view. As we mentioned, if a potential mass is seen in only one projection, it should be called asymmetry until it's three-dimensionally is confirmed. Okay, and another example for a mass seen as a focal asymmetry on the standard CC and MLO view. This is a focal asymmetry, you see, doesn't show the full criteria of a mass. The conspicuity of the mass is not confirmed, is not seen on the standard view, while the spot magnification here demonstrates a mass, a typical speculated mass, and ultrasound is also demonstrates an indistinct, irregular hypoechoic mass proven to be invasive ductal carcinoma. Okay, we said that asymmetries are frequent finding both in screening and diagnostic mammography, and the most common cause for the asymmetry on screening mammography is normal variations and superimposition of the normal breast tissue or summation artifact, as well as island of normal breast tissue. However, may indicate developing mass, may indicate distortion, architectural distortion, or even underlying evolving cancer. Malignant asymmetry is often subtle and can appear identical to normal fibroglandular tissue. And in one study, we described that they found interval cancer that were visible in retrospect appearance of as asymmetry in about half of the cases. Therefore, we said we have to detect early cancer, then we need to pay attention to asymmetries and decide which one it should be further evaluated or just representing summation artifact or island of normal breast tissue. So we should consider it as a significant findings, and therefore it is required to follow approach for evaluation of asymmetry, careful right to left comparison, and comparison with the previous mammogram are vital in this process, as well as supplementary breast imaging should be considered. And we brought this slides including a lot of pathology or long list of pathology from benign to malignant can be presenting as a mammographic asymmetric findings. And we said according to the 5th editions of BIRATS, there are 4 asymmetries. What are these 4 asymmetries? Huh?
السلام عليكم دكتور رباب.
اهلا هنا، تفضلي.
عندنا الاسيمتري، focal asymmetry, 5 types: asymmetry, focal asymmetry, global asymmetry, and developing asymmetry.
Excellent. So we said focal asymmetry, small amount of fibroglandular density over confined portions of the breast, less than a quadrant, visible with similar shape on 2 orthogonal projections. So it is more similar to the mass and should be differentiated from a mass. So being seen in 2 different projections, that means it is a real, you see? But differentiation from the mass, that it lacks the convex border and usually you might see interspersed fat within, while the mass, it's radiodense at its center. This historically was called as focal asymmetric density, but now no more use of this terminology of density to avoid confusions. Global asymmetry, large amount of fibroglandular parenchyma occupying substantial or covering substantial area, at least a quadrant. Visible usually in 2 projections, but it have a concave rather than convex and usually represent a normal variant, previously called asymmetric breast tissue. Developing asymmetry, usually seen more than 1 projections, represent a focal asymmetry that is new, larger, or more conspicuous compared to the previous examinations, with a positive predictive value of ranging from 13 to 27. That means represent BIRAT 4B. It raises moderate degree of suspicion and warranting careful evaluations. Asymmetry is same fibroglandular density without mirror image. However, it's seen in a single projections, either CC or MLO view, not seen in the other standard projections, and almost 80% represent summation artifact caused by superimpositions of fibroglandular tissue, and historically was called as density seen in only a single projections. Okay, we mentioned that the previous historical terminology in the 3rd editions has been replaced on the 4th editions, and no more use of the descriptor density at all at current, since 4 editions, only use the descriptor asymmetry. No more use of density to avoid confusion with the descriptor of density used as reflecting the X-ray attenuation characteristic of a mass. So here we are dealing with what is the appearance of this, representing what? Which type? Global, excellent. Yes, this is global asymmetry, and here this continue focal, excellent. Okay, and this one?
Asymmetry.
This is asymmetry since it is seen on CC, was not seen in the MLO, and this one?
This is developing asymmetry.
This is developing in the illustrations as well as in the CC view, demonstrates asymmetry larger and a little bit more conspicuous compared to the earlier study. So this is a developing asymmetry. And the focal asymmetry, you see, has been seen on about less than 1%, about 0.87% of screening mammography, and has an overall likelihood of malignancy of 0.67, very low probability of malignancy, while global asymmetry occurs in about 3% of screening mammogram and should be considered, as we mentioned before, as normal variant unless it is being associated with mass microcalcifications or distortions, which increase suspicious for malignancy. The only asymmetry having a moderate suspicions and raise the possibility of malignancy per se without associated other findings is developing asymmetry. And with the probability of cancer on screening mammography is about 12.8, while in diagnostic raising up to 27%. However, it's being reported in less than 1%, very uncommon, seen in only 0.16% of screening and 0.11 of diagnostic mammography. And the asymmetry, it is relatively the commonest type of asymmetry, representing 3.3 of all screening mammography. And as we mentioned, up to 80 or 80 plus represent just a summation artifacts, while the likelihood of malignancy is only 1.8 in screening detected cases. But if it is persisting asymmetries, if the asymmetry is persistent, then the reported malignancy, it will raise up to 10.3%. Okay. So how we could approach the asymmetry? What is the practical approach, okay, to evaluate asymmetry?
We do additional views, like the compression view.
Okay, okay.
And,
but as general, last time we talked about how to approach it. Asymmetry.
Yes, if it is associated with the type of the asymmetry, and if it is associated with microcalcification or architectural distortion, or associated with other features like skin thickening, or
yes, what else?
And the localization.
Okay, first of all, we would like, as we mentioned, we would like to confirm adequate technique. Since if the technique is not adequate, it might result in an asymmetry. You see, this is one issue. The second issue, we would like to confirm there is asymmetric abnormalities or asymmetric mammographic findings is there. See, not a mass, not other abnormality. There is an asymmetric findings. Then what is the type of that asymmetry? Okay, then as you know, these types, we mentioned it before. Which type? Is it asymmetry? Is it global? Is it focal? Is it developing? What is the type? Is it asymmetry pure, not associated with other findings, or associated with calcifications, or associated with other features, underlying masses, architectural distortions, or skin changes, nipple retraction, or other or axillary lymph node, or any other associated features? And then we have to localize that asymmetry as we described before by the descriptor of localizations. Okay, so let us go through this. Here we have an asymmetry in the CC view, not well appreciated in the MLO. So this mammogram demonstrates asymmetric abnormality, not seen in the other standard view. So we call it, we prove that there is asymmetry and not seen in the others. That means we are dealing with asymmetry. See? And these patients having clinical history, okay, of surgery. So we have to consider what? We have to consider in history of surgery, we expect the fat necrosis, you see? And it's being proven here on ultrasound. This is mixed, ill-defined mixed echogenicity or hypoechoic with hyperechogenicity, okay? Going with the fat necrosis. Okay, the second example, 60-year-old lady screening mammogram. Demonstrate what? What you could say you could see here, compared to the contralateral, there is asymmetric findings seen on the left side, periareolar region, seen in the CC as well as on MLO, not extending over a substantial area, not extending over a quadrant. So we are dealing with
Focal asymmetry.
focal asymmetry. So we are dealing with the focal asymmetry. What is next? This is the next. The next is spot compression view. Demonstrate what? Spreading or disappearance of that asymmetry signifies that it is a normal tissue. It is an island of normal tissue. And stereotactic core biopsy was performed and demonstrate a normal proven that it is a normal breast tissue. Okay? So we said focal asymmetry seen in two projections. It is real. It is real. We commonly represent an island of normal breast that is might not even disappear on a spot magnifications view. You might see it. We need to differentiate it from real lesions. If there is no history of surgery, trauma, or infections, okay, we have to take it seriously and we have to exclude malignancy. And we said it is worrisome if associated with palpable abnormality or associated with skin changes or associated with distortions, suspicious calcifications, or what? Then we have to consider it as a suspicious findings, and we have to proceed, do ultrasound or use other, if it is not seen on ultrasound, use other modality to do biopsy. And what about this? Okay, here there is asymmetry as well as associated axillary adenopathy. Spot magnifications does not disappear. The asymmetry is there. 72-year-old patient, her previous mammogram was normal. What does it indicate?
Developing asymmetry.
So it is, we are dealing with a developing asymmetry. So, and it does not disappear. What does it mean? Being not disappear on spot compression, it means what?
It is a real
It's a true.
It means it is a real. It means it is real. And And it is developing asymmetry, not a superimposition of tissue. And what is the clinical question would you like to ask this lady?
Any history of trauma, any history of
Excellent.
surgery, any history of surgery, any manipulation.
Yes, excellent. History of surgery, history of trauma, what else?
Infection.
Infection, what else?
Hormonal replacement therapy.
Excellent, excellent, well done. History of hormones, hormone replacement therapy in this elderly lady is really important. Or any palpable abnormality. Okay, so this lady having a developing asymmetry, okay, in her left breast, not disappear or not dissolve on the spot compression, and at ultrasound there was a mass, okay, and biopsy proven to be invasive lobular carcinoma with metastasis to the axillary lymph nodes, okay? So confirming a developing asymmetry, assume that true lesion maintain their dimensions at the spot compressions. The reason is what? As I ask you for that, yes, it is real, but why carcinoma does not disappear, or it maintains its size and shape on a spot magnification? Why it doesn't show change or significant change?
It's hard.
What?
It is hard.
Hard, excellent. Why? What does it indicate? What does it mean? Being hard, yani. What does it mean being hard?
It is fixed to surrounding structure.
Yeah, excellent. Fixed to surround. Why it is fixed?
The reaction of the normal tissue to the reaction of the malignancy itself.
Who is talking? Who's talking?
I am Sarah Al-Makki.
Sarah Al-Makki, you're welcome, Sarah. Yes, the desmoblastic reactions, fibrotic reaction usually make it fixed. You see? One reason is that carcinoma and surrounding tissue undergo desmoblastic response, much less likely to change on dimension on compressions. You see? So we are dealing with developing asymmetry, in this case due to invasive lobular carcinoma. And as we mentioned, usually it is BIRAT 4, the developing asymmetry. So sometimes the developing asymmetry seen on only when projection of standard screening or diagnostic mammogram. And on screening, it might be seen on when projections, and when you recall the patients and do diagnostic mammography, it might still continue to persist on when projections, you see? But if you see it in a single projections, don't say this is an asymmetry in a single projections. It is not a suspicious. Since it is a developing asymmetry, if it is seen in a single or more than one projections, we have to take it, or we have to consider it as BIRAT 4 until proven to be downgraded. See? Downgraded by history, by ultrasound, by additional projections or spot magnification or whatever. Otherwise, we have to consider it as a suspicious, regardless it is seen in a single projection or seen in 2 projections. This example, 60-year-old lady who lost 45 pounds or 20 kilos in the 2 years since her prior screening mammography. So, this is the earliest, and this is after 2 years. And this is a spot. What is your impression?
There is a developing asymmetry.
Yes, developing asymmetry. Okay. So what is your impression?
And as she has an associated
Abir?
symptoms, yes. Assalamu alaikum.
Alaikum assalam wa rahmatullah. Huh?
As she has associated symptoms like weight loss, so developing asymmetry is by RAT 40, so we have to proceed for further workup.
Okay, what about the spot?
Still, the asymmetry is present.
Okay.
It has been spreaded, but still, I could appreciate some abnormalities.
Yes, you are right. Is spreading is not, there is no underlying mass, no distortion, no calcification, no suspicious features. The only things it is spreading tissue. So it's not a rigid, it's not a fibrotic. It shows some changes. Okay, so are dealing with fibroglandular tissue. And this developing asymmetry is due to the weight loss. See? In comparison with the initial, there is 2 years initial mammogram. There is apparent developing asymmetry in the upper outer quadrant. The MLO is not there. Okay. Subsequent left spot compression, it disappears due to summation artifact or pliable fibroglandular tissue without the resistance of focal asymmetry. No associated suspicious. So just they are going to follow it. Okay. And it was stable until over the next 2 years. It was stable. So it was only this asymmetry or developing asymmetry is due to the weight loss. Okay. What about this lady? This lady okay, she has first round 2010, the second one 2013 demonstrate developing asymmetry. And what about the 2014? What happened for that asymmetry?
It decreased.
Decrease. What does it indicate?
Maybe she was on hormonal replacement therapy and then she stopped it.
Excellent, well done. Yes. So what happened? This having developing asymmetry. The woman was in intrauterine using a hormonal releasing intrauterine device. See, it started in 2011 after the first screening, and then you see the 2013 demonstrate the developing asymmetry. After that, her ultrasound was normal. Discontinued her treatment before 2014. That is why the developing asymmetry start to regress. And this is normal breast parenchyma due to hormonal response. And as we mentioned, the differential diagnosis of developing asymmetry long list, starting from benign tissue summation artifacts, cyst, fibrocystic, fibroadenomatoid, fibroadenoma, pseudoangiomatous stromal hyperplasia, fat necrosis, we have scar, papilloma, angiolipoma, lupus mastitis, nodular adenoma, ductictasia, intra-mammary lymph node, radial scar, trauma, and we have seen example for weight loss, and even weight gain can give you asymmetry, and we have seen this due to hormonal response, hormonal replacement therapy, or any exogenous hormone is taken by the woman might result in developing asymmetry. And we should not forget always to exclude malignancy, including infiltrating ductal lobular carcinoma or mixed including even DCIS, tubular or mucinous carcinoma, as well as lymphoma. Okay, and here this is an example of a benign developing asymmetry due to benign tissue or benign lesion, which is pseudoangiomatous stromal hyperplasia. Look here, this is the earlier mammogram, and in the follow-up mammogram demonstrate this area of focal asymmetry or developing asymmetry. Okay, and this here on ultrasound in both, this is the previous ultrasound and increasing in the follow-up ultrasound, and the biopsy, core biopsy reported as BIRAT 4B, okay, and reported core biopsy revealed pseudoangiomatous stromal hyperplasia, but because it's increasing in size, surgical removal demonstrated still pseudoangiomatous stromal hyperplasia. However, even the appearance might give impression that it might be benign. Biopsy is indicated since it is developing asymmetry. And this is another example of pseudoangiomatous stromal hyperplasia, also demonstrate increasing or progression since earliest mammogram. In the second mammogram, this area reflecting the site of biopsy, and it was stromal, pseudoangiomatous stromal hyperplasia. However, after the follow-up that demonstrate progression of the lesions, surgical excisions revealed also just pseudoangiomatous stromal hyperplasia. Okay, so developing asymmetry that cannot be accounted for by differences in imaging technique and positioning, or attributed to weight loss, hormonal replacement therapy, surgery, trauma, or infection at the site, it should raise suspicions. And if focal asymmetry develop in patient undergoing hormonal replacement therapy, we have to repeat mammography after discontinuation of therapy. Let the patient discontinue therapy and repeat mammography. If it is regressing, yes, it is related to the hormonal therapy. If it persists, okay, not resolved, you have to proceed for biopsy to exclude malignancy. A developing asymmetry that becomes less evident but still persists after discontinuation of hormonal therapy, you have to follow it up. You have to follow it and to make sure what is the nature of that. It can be just still estrogen sensitive breast cancer. Okay, what about these patients? 60-year-old female, asymptomatic for screening mammogram, the previous and current. So here, Alaikum assalam. Bilateral. Here we cannot say asymmetry because it is mirror image. We can say there are diffuse bilateral increased density. You see? And since it is bilateral like this, in a 60-year-old female, we suspect, but it is developing. It is developing since the previous,
Most likely due to hormone replacement therapy.
Yes, so this is, it is bilateral. This is hormonal replacement therapy, and this is, it will be clear. Being globally bilateral, more or less symmetrical, it will be easy. You see, when it is diffuse, dense, but sometimes it can be focal. It can be unilateral. It is not always giving, bilateral mirror image increased density. When it is focal or when it is unilateral, then it will result in a challenging abnormality or challenging problem, especially in the elderly woman. And as we mentioned, ask the patient to stop or discontinue the hormonal replacement, repeat the mammogram. If it doesn't dissolve, okay, then proceed for biopsy to exclude malignancy. And here the differential diagnosis will be mastitis. If it is unilateral, it will be mastitis, inflammatory carcinoma, congestive heart failure, and as we mentioned, the hormonal replacement therapy. And if it is bilateral, congestive heart failure is still there, or rarely can be bilateral inflammatory cancer or mastitis. Okay, and what about these patients here? There is focal asymmetry on the right upper outer breast, spot compression, demonstrate persist, depicting irregular margins and speculations. If you look for the standard view, is not as impressive as the spot compression view. So on a spot compression view, it will be BIRAT 4C. Core biopsy demonstrate ductal infiltrating carcinoma. So this is a focal asymmetry. Focal asymmetry, we said most of the time it is island of breast tissue, but it still can represent infiltrating ductal carcinoma. So we have to be aware. And if you look at the standard view, is not so impressive that it represents a cancer. So it is subtle presentation of cancer. However, more impressive on spot compressions. And what about this? Screening mammography, 72-year-old woman with no breast-related history. Huh? What is abnormality? Okay. No asymmetry here?
Global asymmetry.
There is
Global which side?
The
Global
right
which
one.
side?
The right breast.
Excellent. Right global asymmetry, not associated with suspicious features. So represent normal fibroglandular parenchyma. Okay? And it was stable for 10 years. So after that, it will be BIRAT 2. Yes. Okay. And this is my patient. I have shown to you last session.
طيب دكتورة باب, what about the left breast in the previous case?
This one, yeah?
Yes.
This area?
Asymmetry.
Yeah, it seemed to be here, but it may or may not be a real asymmetry. You see, in the other view, it doesn't show. But the more impressive is the global asymmetry. I have seen it, but they did not mention it. This is a SER case. And they followed the patient for 10 years. It was not there. This is my patient. This one I have shown to you last time. Demonstrate what, Sarah? Since you are in the
global asymmetry of the left.
Yes. What do you think about it? Representing what?
Yes. It could represent fibroglandular tissue.
Yes, yeah, you are right. Excellent.
Yes.
So this is global, this is normal fibroglandular parenchyma since there is no any associated suspicious findings, and it was stable on follow-up mammography. So global asymmetry is asymmetric tissue that occupies at least one breast quadrant. Is visualized on 2 or more projections. On one, I mean, or even 2 or more projections, almost always benign abnormalities. Almost always benign abnormalities and requires no additional evaluation. If there is no this, it doesn't need additional evaluation if there is no corresponding palpable abnormality, no associated architectural distortion, significant calcification or suspicious calcification or masses, then it will be BARAT 2. This finding is usually due to developmental variant or due to differential and organ response to hormonal stimuli. Also, differences in imaging technique and positioning might result in an asymmetry. As we mentioned, weight loss, hormonal replacement therapy, surgical procedures could also cause global asymmetry. However, occasionally it may indicate the presence of underlying breast cancer, especially if there is associated palpable abnormality or mammographic suspicious features. So in this case, in these clinical settings, we should recall the patients if screening mammography and additional imaging evaluation should be performed. Okay, so we pass and confirm technique, confirm there is asymmetric type. لو سمحت, would you please close your microphone? There is one child is talking. Let us see what is the associated features. What about this?
In the outer quadrant of the left breast.
So here,
Yes.
you are welcome, huh?
Assalamu alaikum.
Alaikum salam.
There is focal asymmetry at the upper outer quadrant of the left breast. On these
All
images,
this. If you look for the parenchyma, this is a disc. That is a disc. If you divide it, it's almost occupying the whole quadrant. So
global asymmetry.
It is global asymmetry. It's okay.
Global
so
asymmetry.
There is global asymmetry.
And on these images, I couldn't see any associated feature, no skin thickening, no calcification, no axillary lymph node enlargement.
But you did not say no distortion.
There is architecture distortion.
Yeah, subtle distortion is there. And what about the history? Did you see the history? Up?
No.
Obscure? It is written palpable abnormality. Palpable abnormality.
I have to do a spot compression view to see any suspicious microcalcification or not.
Okay, a spot doesn't show suspicious microcalcification. So still, it does not disappear. It persists. Next.
So it's suspicious. The next, it's suspicious for BIRAT 4B for biopsy. No, for ultrasound. Sorry.
For ultrasound. Excellent. This is ultrasound.
Ultrasound, it is ill-defined mixed echogenicity, hyper and hypoechoic areas.
So what does it mean?
It means fatty lesion.
Why is it fatty lesions? This fatty lesions or this heterogeneous area? Heterogeneous like, yes, ill-defined heterogeneous ductal like. You see tubular like segmental ductacesia. So
yes,
and indistinct and heterogeneous, not clear. So
it is a BIRAT 4.
BIRAT 4
4C.
for biopsy. Yes. So it is we have to consider the palpable abnormality even if there is no subtle distortion. You see?
Okay.
And ultrasound findings are suspicious. Ductal abnormalities or ductal segmental ductacesia. See, with some heterogeneity and suspicious features, and it was DCIS. Okay? So this is global asymmetry, but in this patient, I will not say that since it is global asymmetry, it has to be normal. So we have to consider the associated features. Now, what about this one, patients? This is also my patient. The previous one, this is from literature, but this is my patient.
Again,
This is
again, there is global asymmetry on the left breast.
Yes, excellent.
The next step is spot compression view.
There is palpable abnormality. Okay.
Compression view, if available.
Why you want to do compression in global asymmetry?
To detect it is real.
Here it is almost the whole breast is occupied by this global asymmetry, not only quadrant, not only.
Okay.
Yeah.
So ultrasound should be
ultrasound here,
yes.
And there is palpable abnormality. So I will go for ultrasound.
Ultrasound.
Okay, this is the ultrasound. So
ultrasound show an ill-defined lesion.
suspicious finding, it demonstrates suspicious finding, and it was invasive cancer. Okay, so this is screening mammogram. We want to go quickly to complete the to go through all of the examples we brought. Huh?
Global asymmetry on the right side.
Okay, global asymmetry on the right side.
Ultrasound.
Can you change your mind?
Or could be yes,
ultrasound?
or to be localized more to the upper outer
Even
outer
in
middle,
the previous
outer
example,
middle.
you didn't ask about the other.
The
view.
previous one.
But in the previous example, it was very clear that the global asymmetry occupying the whole breast. Here, why did not ask about the CC view?
So we can see CC view to localized.
Yeah, how you can read? You read the mammogram only one standard view without looking for the other view. Okay, this is the other view. So
yes, there is.
So you change your mind or not? The
yes,
finding in which side? Abnormal finding which side?
Finding on the left side.
Left, which side? Left.
Left upper.
أيوة.
Upper outer
Left,
quadrant.
left upper outer. Left
yes.
upper outer. There is
yes.
asymmetry associated with
nipple retraction.
And if you go back for this MLO, you will see the subtle distortion more evident on the CC view. If you look for these lines, these spicules, this is a distortion. These are distortions. And if you look here, there is subtle distortions. And even all these asymmetry. So it is a global asymmetry with distortion and associated. Even if you look there, you will see the subtle nipple retractions. And there is subtle thickening also in the other view. So you are dealing with suspicious findings. Okay, by
yes.
RAD4
Or
C.
B. Or
For
C.
C. This is for
Okay.
C.
Yes.
For biopsy. Okay. And that was, I don't know, it should be, and I would like to show you this is before the diagnosis. It came together. Let me see. Sometimes change the animations, I don't know. Okay, so this is a spot magnification now. After a spot, it will be
Yeah.
more
There is
suspicious.
suspicious. With,
There is an irregular
with,
mass.
yes.
There is an irregular mass-like lesions. So it is at least it is BIRAT 4C, and that was invasive ductal carcinoma. Okay.
Yeah.
So the associated feature we described it before: skin thickening, nipple retraction, skin retractions, trabecular thickening, axillary adenopathy, architectural distortion, calcifications. All these we have to consider it while evaluating the asymmetry. So we went through the associated features. Let us see the associated calcifications, also part of the associated features. And in these examples, there is area of focal asymmetry, inner lower left breast. Subtle distortion is there, but we could not appreciate the calcification. But in the spot compression magnification, there is heterogeneous microcalcification. So presence of this heterogeneous microcalcification associated with asymmetry increase the level of suspicions. Ultrasound demonstrate hypoechoic, irregular, indistinct hypoechoic area, and MRI demonstrate non-mass-like enhancement. So it become BIRAT twice, and biopsy revealed ductal, infiltrative ductal carcinoma. You see, as we mentioned, though focal asymmetry usually represent island of normal tissue, lack of specific benign findings warrant further evaluation, because ill-defined mass might appear, or ill-defined cancer might appear as asymmetry. So we went through all of these, then remaining the descriptors of locations. So any volunteer to tell me how to localize this asymmetry?
Okay, this asymmetry is within the left
Asymmetry,
breast.
what is the type of asymmetry first?
This is focal asymmetry within the
focal asymmetry.
left upper outer quadrant
Excellent.
of the left breast.
Left upper outer quadrant, huh?
Yes. Okay, with the clock position, it is it within. باخد فيها زمن شوية الكلوك position. Almost
Okay.
1 o'clock. It is, yes, left. It's within 2 o'clock position.
Excellent. 2 o'clock. Excellent. 2 o'clock position.
Yes. And it is within the middle, mid of the
Excellent.
breast. Yes. Okay.
سارة مش كده؟
أيوة. انت كده.
Okay, you are right. This is in the left laterality, left breast quadrant, and clockwise upper outer quadrant about 2 o'clock. Depth is middle, and the red line, you have to mention it. The red line represents the distance from the nipple. Okay? Red line in centimeters. The distance from the nipple. We should not forget that. This is the descriptor of locations. So it is a focal asymmetry seen both in MLO and CC view. In the left, middle, upper, outer quadrant about 2 o'clock. Okay, so now we have idea about the general approach for the asymmetry. We said we have to, okay, evaluate first the techniques. So it might be the cause for the asymmetry to make sure is proper positioning and proper compressions. Then we have to make sure there is an asymmetric findings on mammography, then to classify which type of asymmetry, then looking for any associated calcification or other associated findings, and finally describe the locations of the. We'd like to go a little bit more detailed in the evaluations, okay, and management of asymmetry. Okay, let us go together through an algorithm, okay, and to show the practical workup that can be used for characterization and management of asymmetry. So if we have asymmetric findings, first of all, we confirm there is asymmetric finding. We reach this area. So we need to know first if it is one projection or two projections. Okay, so if it is one projection, then it will be
Asymmetry.
asymmetry. Okay, so if it is asymmetry, then what I want to do?
Compression, magnification, compression view, spot compression.
Okay, why?
To see if it's summation of breast tissue or
Yes.
a real lesion.
Yes, I would like to make sure is it just a normal breast tissue or a real lesions? Okay, so if it is seen on two projection, it will be
It will be either focal or
yes,
or global or developing.
yes. If it is less than one quadrant or more than one quadrant or progressing or new. If it is more than one quadrant, it will be global, less than one quadrant focal or progressing or new, it will be developing. Okay, so I need to go further to differentiate all these types. Is it just an asymmetry, normal tissue, superimposition or island of normal tissue or whatever normal variance, or a real lesion, or there is any underlying real lesions? So I have to go further by additional. Okay, I can do additional mammographic views. What else? Apart from additional
Or
mammographic view,
ultrasound.
ultrasound, what else? What else? Additional mammographic views, ultrasound, tomosynthesis or MRI. Okay, so spot compressions or other mammographic views, ultrasound, tomosynthesis or MRI. Okay, so if it is summation artifacts, if it is summation artifacts, that means it will be BIRAT
1.
Okay, so it will be normal. If it is not summation artifact, no, not summation artifact. So I will look for any associated abnormality, microcalcification, distortion, or associated palpable abnormality. If it is yes, it will be
4.
For it's suspicious, I have to proceed for biopsy. If it is no, not associated, I will ask for if no associated palpable abnormality, microcalcification, or distortion. Here I need to have
I will ask for history of surgery, trauma.
history of trauma, surgery, or weight loss,
Hormonal
hormonal,
replacement therapy.
yes, hormonal therapy, whatever. Any hormonal therapy, even those premenopausal. You see that the lady using the intrauterine device, hormonal type of intrauterine device, not necessarily hormone replacement therapy, but hormonal therapy in general. Okay, so I would like to ask about this. Okay, if it is there, if there is history of this, then I'll consider it probably benign and I will follow it up. If there is no history, then if there is no history, if no history, I will consider it as
Suspicious.
suspicious. I will consider, and there is one of these asymmetry from the beginning, regardless, and I have to raise the suspicion until proven not a suspicious finding, which is
The developing thyroid B4,
the developing
B.
asymmetry. Okay, so now we went through the algorithm. Okay, we understand the algorithm. We'll go through examples. Before going through the examples, detection and diagnostic evaluation of developing asymmetries is particularly challenging, as may appear as similar to fibroglandular tissue at mammography. Even if it is representing malignancy, it might just appear as just a fibroglandular. Once asymmetric findings is perceived, it should necessarily to determine whether it is three-dimensionally real due to definite lesion or just projection artifact or superimposition of normal tissue. Okay, so this is an example here. You have this represent a focal asymmetry. Use what we have to do, compression and other views. Use the spot compression view to demonstrate summation shadow. On the asymmetry, right breast, further evaluation of asymmetry, we have also a straight lateral view and a spot compression magnification view were obtained. Demonstrate that the asymmetry disappeared. This asymmetry is not seen on a spot or on the straight lateral view. So most likely it will be
summation artifact.
Summation artifact. And even on the follow-up, okay, in 2 years, it doesn't show any asymmetry. Okay. So, but if you look here, this is asymmetry or focal asymmetry. Which type of asymmetry?
Asymmetry.
Huh?
Asymmetry.
This is asymmetry. Why asymmetry?
It's appreciated in the CC, but not in the MLO.
Okay. If I'll ask you, are you confident that it is an asymmetry or it might be a focal asymmetry?
I'm not so confident because there is something, but it's not the same shape. I mean, there is something in the MLO, but does not have the same shape.
No, it doesn't. It doesn't seem on MLO. But my question's in the other way. When we have seen, okay, an area of asymmetric findings in a single view, we have to look for in the other view, searching for the same area
Yes.
of
Yes.
asymmetric findings. Do you agree?
Yes,
When
I
we will
agree.
be confident, when we'll be confident enough, okay, that it is not, definitely it is not in the other view.
We in the previous lecture you have started mentioning the arc that we should measure the distance between the lesion and the nipple, and then we draw this.
Before that, we were talking about the lesion locations and the probability of being disappear or appear in the other view. We said what are the factors that affecting the visibility,
The fact, yes.
the visibility of the lesion and disappearance or non-conspicuity of the lesions in the other view.
Yes,
Technique.
it's not.
Technique.
Yes, it
Huh?
is not.
Technique.
It is not the posterior part. Technique.
Yes. Yes, you are
First,
right. You are right. You start correctly. It is not in the posterior part. Excellent. So
yes.
if the lesion is posterior, close to the chest wall, seen in one view, one projection, you might expect in the other view that is not included in the field of view in the receptors. You see, it might not be included in the covered in the receptors, that is excluded, is not seen in the other image. But if it is seen far anterior in the middle or anterior breast, so you don't expect to be excluded in the other view. It has to be within the receptors. In the receptors, it has not be excluded. This is one criteria. You
The other thing is the composition of the breast.
location of the lesion the location of the lesion makes the possibility to be excluded is unlikely. Okay, this is one issue. What other issue?
This is fatty breast, so the possibility is over superimposed by fibroglandular tissue is not there.
Excellent, well done. Is a fatty breast, so there is no fibroglandular parenchyma that might obscure this asymmetry in the other projections. Okay, what else? Well done. What else? Okay, so an asymmetry can confidently be assessed as representing summation shadow without the need for additional mammographic views when the asymmetry is visible on only one of the two standard mammographic views, and the asymmetry is sufficiently anterior to the chest wall that it must be included in the image field on the other standard view, and the breast has sufficient fat content that on the standard view not showing the asymmetry. There is no concern about substantial additional dense. And we said that if we have previous, we have to compare with. And in this case, we have no previous, but we have spot compression, and the lesion is all spread away, and we have straight lateral and doesn't show the asymmetry. That means this is definitely just a summation artifact. Okay, so it is an asymmetry and due to summation artifacts. Okay, as we mentioned, breast varies in positioning from one examination to the next. That means what? We should expect that regions of asymmetry will be seen at least in one view, and this may not correlate with geometric focus in the other view. Why? From one position, from one standard view to the other view, the breast is being changed in position. But this change in positioning might result in some asymmetry, seen in one projection, not seen in the others. Or differentiating asymmetry seen on only one single from focal asymmetry seen in two view, okay, which is either due to summation artifact or obscured by the other, is obscured on the other view. So we need to keep closing to the other view. We looking for that abnormality in the other view, keeping in our mind the size of this abnormality or lesions, the density of which, the depths, as we described before, while we are looking. And we have to compare the two projections at mammography, can be one of the methods for determining whether this suspected lesions is real or not. And there are, according to that, there are two methods for triangulating the lesions, as we described it before. We said, what are these two methods?
The arc method.
Arc method's excellent, and
Straight line.
yes. It means determining its location on one projection in which it appears and then evaluating the corresponding tissue on the other projections. We have two standard, or we have two methods for the triangulations of the lesions, as we described, the arc methods and the straight methods, okay? They have the same principles. We look for the lesions appear in which projections. If it appear here on the MLO, we draw a line from the nipple to the lesions. And we took the same, okay, apply it in the other projections, same lines. And then we use it as a radius of an arc. See, a radius of an arc, and we swept the arc in that area, and then we expect the lesions or the abnormality, it should be seen within the tissue along this arc, okay? If we could see it, that means it is a focal asymmetry. If we could not see it, that means it is not real, and it is just, it might be summations, or it's just an asymmetry, not a focal asymmetry. And the straight lines, just you will take the same, you will do the same, the vertical lines from the nipple to the lesions, and you will draw a line from the lesion parallel to the chest wall. And you will take the same, okay, for the other view. And you will go through that lines, along that lines, okay, the tissue along that lines, you expect that the lesion, it will be within. If you could see it, it's okay. That means you are dealing with the real things. If you could not see, there is no corresponding asymmetry seen, so you regard it as just asymmetry, not a focal asymmetry. Okay? However, the tendency to rely on these conventional projections only, it might result in obstacles for proper evaluation of asymmetry. The breast might be too much dense, or it is not just, you cannot totally depend on that to say this is an asymmetry. It is helpful, but we cannot completely depend to exclude that it is a real lesions, or it might be a focal asymmetry also. So, although it can be inconvenient, if you see that, on screening mammography, just call your patients, okay? Recall the patients and base your management on sufficient information. Don't take it like that lightly. Once a patient has been called back from the screening examination for developing asymmetry, diagnostic mammography should be performed to determine if the developing asymmetry is true lesion and to localize it in three-dimensional space, even for the focal asymmetry. Okay, if it is not, if it is seem to be more or less real, we have to proceed and evaluate it further. However, we are saying developing because it is a more concerning asymmetry, concerning lesions. To interpret and manage asymmetric breast finding, then we need to use additional mammographic view like compression views and straight lateral and other mammographic views. We'll go through this as well as ultrasound, tomosynthesis or magnetic resonance, you see? And we should apply it appropriately in logical workflow, and radiologists also should be aware about the pitfalls and peers for these techniques. We cannot put it like that. When you have to do this, second you have to do, no. It is, it depends on the case. So how do we decide if one view asymmetry is important? True lesion might appear only on one view. We have to put this in our mind because on the other view, they are either obscured by overlying dense parenchyma or in anatomic locations located outside or beyond the image receptors, the field of view, beyond the field of view, like in the axillary tail, okay, or in the posterior locations, you might not see it in the CC view, or in extreme posterior medial, not seen in MLO, or in the superior breast, not seen in the CC view. We describe all these in the positioning mammographic in the mammographic technique lectures, or suboptimal breast positioning during mammographic examinations. See, the breast is not well positioned in the so some of the breast being excluded from the image, not fully included all breast tissue. And this, as we described before, you might evaluate it by the posterior nipple line. You might find far more than 1 centimeter between the two standard view. Okay, an asymmetry that is in the posterior third of the breast may have been excluded from the other projections as we described before. So additional view tailored to ensure that the proper amount of breast tissue is on the image receptor to assess the findings in questions. And if asymmetric findings is three-dimensional real, i.e. seen in two projections, then we must decide whether this is caused by an island of normal breast tissue or a true lesions. As we described before, focal asymmetry is the real, since it is three-dimensional. It is seen in two projections, but still it can just represent the normal tissue. But being real, it doesn't mean that being a lesions, true lesions. After we prove that it is a real abnormality or seen or observations, we need to make sure that it is a real lesion or not. So we might still need to have additional mammographic views, okay, to obtain the differentiation between true lesions obscured by overlying parenchymal dense parenchyma on the other projection from summation shadow from island of tissue. So the most important is or the commonly used is spot compression with or without magnification views. Okay, as you have seen in these examples, this area of asymmetry seen on the MLO but could not be appreciated on the CC view. So we are dealing with asymmetry. However, spot magnification view seen dissociations of this normal tissue. So the spot magnification is usually subjecting small focus to more targeted and vigorous compression. So summation shadow or pliable tissue, you see, it will spread away. It will spread apart, you see, revealing no focal abnormality. But if there is a real abnormality, spreading of overlying breast tissue, spreading away, it will make it more clear, more obvious. And we said the vast majority of asymmetries and focal asymmetries are summation artifact, and focal asymmetry represent island of breast tissue. Okay, see these examples. See, so we are dealing here with focal asymmetry, since it's seen both on CC and MLO, but not very obvious. Yani area just it's more denser than the adjacent tissue, but not giving the conspicuity of a mass. However, the spot compression view demonstrates that that is representing a focal circumscribed mass, oval circumscribed mass. Why? Because by adding compressions to that area, spreading the overlying tissue, obscuring this underlying mass. You see that if asymmetric findings seen as three-dimensional, seen in two projections, we need to decide, is it caused by island of normal tissue or true lesion? In this case, it represents true lesions. Okay, so by adding compression view, we could characterize it. We could give more characterization. We spread away the overlying breast tissue and helping us to give more characterization of the underlying lesions, which is also seen here on ultrasound. Both there is oval circumscribed and here is oval parallel hypoechoic. So it is probably benign BIRAT3 in both mammography and ultrasound. And in these examples, also the focal asymmetry, just an denser tissue, focal area of denser tissue seen in MLO and CC view. And still here, it doesn't show a real lesion. It shows like an area of just a focal asymmetry. Still, there is focal area of added density, which is a focal asymmetry. So I need to go further for ultrasound to characterize it. So we are dealing with just a probably benign focal asymmetry. It doesn't, it neither change nor dissociate. It persists, but still, it can just be an island of breast tissue. And we mentioned before, it might not, if it is represent not a superimposition of tissue, just an island of tissue, focal asymmetry, it might persist on spot magnifications. And ultrasound doesn't show any abnormality. So how you are going to code it? What is BIRAT? Huh?
Two.
Two,
Sorry,
why two? Why two?
sorry. One, I mean one.
Why one? One, if it is spread away, if you have just a summation artifact, but still you have a focal asymmetry. Still you have a focal asymmetry. Ultrasound doesn't show abnormality, but still spot compression view demonstrate, and even the spot compression view, they have done with different angles. They have done the same CC view, and here not MLO. They do the spot compressions on the straight lateral view. They change the angles, which is also helpful.
So
So
three.
we are dealing with 3. The findings should be assessed at category 3. You got it? We have to consider it as 3 and follow it up. We don't know what is going on. Okay?
Okay.
So why we have done the compression, the spot compressions, both straight lateral and CC? Why you did not do only, we have seen here on CC view and it appeared on compression view. Why we do 2 different compression view, not only 1 compression view? Why we have done 2 different projections for spot compression view rather than single projections in asymmetry? In a case of asymmetry, why I have done 2 projections? And is it necessarily or just it came by chance? Anyone knows? Okay.
Maybe because I didn't reach the full characterization of the asymmetry by one view.
Okay, okay, you are right. They recommend that never just spot compression and asymmetry on one view, always obtain additional view in both projections. See, never do one spot. Why? Why? Spot compression in the same projection as standard mammographic view may produce only the same superimposition of structures and not differentiate a lesion from the summation shadow despite increased pressure, as we have seen in the previous example. The focal asymmetry, it doesn't show significant interval changes from the standard view between the standard view and the compression view. So you need to go with the different angles. Okay, so it might show some change, and there is presumptions applied particular to cancer that the surround desmoplastic fibrotic response make it less likely to change their appearance, even vigorously apply focal compression. The spot compression is more vigorous than the standard compression. It might not change. However, there are uncommon exceptions, okay, to these general observations. What is that of exceptions? Some cancers are not associated with high density of tumors, so it might appear, it might be affected, it might be become less dense on spot compression and give erroneous impressions. Also, some cancers might have not sufficient desmoplastic response, so it might slightly give some change between the standard view and spot compressions. It might slightly spread away on spot compression because it is less dense or less associated desmoplastic reactions. So this definitely might lead to erroneous conclusion that we are not dealing with cancerous tissue. On summation it might represent just a summation shadow. That is why if the lesions might still not completely spreading away, we can consider it as probably benign rather than para 2 and just follow it up rather than just say this is nothing. And that is why we need to do different angle spot compression to avoid these challenges. Always obtain additional view in both projections, since even malignancies may spot compression away. We don't like, so if it is not associated with tough fibrotic tissue, it might give some impression, some spread away and give false impression that this is not a cancerous tissue. So, second, some regions of the breast in which there is more focal accumulation of fibrotic tissue may be accordingly more resistant to being spread apart by spot compression. Some fibrotic breast tissue, non-cancerous fibrotic breast tissue, might persist, might not spread away, also can give you erroneous impression of being malignancy, but it is not a malignant tissue. So definitely any rules have exceptions, and we have to consider these exceptions. When asymmetries are fixed and focal, okay, but appear to spread away with spot compression, ultrasound may be valuable in averaging and in averting the erroneous conclusion that a lesion does not exist. We have to use the ultrasound to give better clarification and characterizations. Okay. And we have to be aware about the pitfalls. This example here, there is asymmetry here, okay? This the Ferris spot compressions, but was not, the asymmetry was not at the center of the compressions, at the periphery. You see? Seen as if it is in the standard view. It doesn't show much change. But when they center it here, you see the adjacent tissue, fibroglandular tissue, summation tissue, spreading away and demonstrate and speculated mass, which demonstrate infiltrating carcinoma on core biopsy. So even we said at the beginning, if the tissue of concern is not appropriately placed in the receptors, might give false impressions, even on spot magnification, not in the standard view. On a spot magnification, if it is not properly placed, it might give you not good result and might not be helpful, as we have seen in these examples. See, we have to do it properly, and we have to avoid the pitfalls. A focal compression is applied in the lesion, also can be rolled or squeezed out of the field of view, leading to incorrect impression that is not real. You see, look here, this is at the periphery. It might even be slipped away. It might not be seen even in the field of view, and might give you just impression there is no asymmetry here. And this, you might report it as it is spread away. So we have to be sure that the area of concern is being included in the spot compressions, and it is really spread away, and there is no aerial lesions. If they did not repeat it here and make it correctly, the mass might not appear, and here it might also be slipped away, rolled away, and even while they are doing the compressions, if they compress it against the area of fat, roll it away toward the area of the fat to make it more clear, it will be more helpful. Okay, and look for these other pitfalls. This dense breast, demonstrate a focal asymmetry here. If you look here, it is the same, or it doesn't show much change. It is also same density, just an area of focal asymmetry. It might give impression this is just might be an island of a breast tissue. But by doing ultrasound, it demonstrates a probably benign mass, but with overlying parenchyma, obscuring this mass. That is why it doesn't be appreciated in this spot magnification, spot compression projections. You see? That is why we said if you try to push it toward the area of the fat, it might be helpful. Okay. We finish the spot compression view with or without magnification. We have other projections. Okay, supplementary view, we discussed it in the first lectures of mammographic positioning. We said we have 2 standard view, but we have many supplementary views. We can use it in certain conditions. Now we know how compression, spot compression view help us in evaluating the asymmetry, especially by adding more pressure or more compression. It might, the summation artifact might spread away, or in a real lesion, spreading of overlying tissue might help us to further clarify it and with better conspicuity of the underlying real lesion to furtherly characterize. Okay, let us go for the other view, which is straight lateral view. If we see, if a lesion is seen only on the MLO, it may be obscured on the CC. Do you remember which areas not seen in the field of view, in the MLO and in the CC view? Yes, we have mentioned during these lectures. We said in the CC view,
The
lateral toward the
yes, the posterior lateral and superior breast, it is commonly not being or common missing areas on the CC view, while in the MLO,
medial posterior.
the posterior medial is can be missed in the MLO. Okay, so if the lesion is seen only, do you know which when we use the straight lateral view for triangulations, we describe this in the positioning lectures. We use it when to triangulate a lesion.
Which is seen in the MLO but not seen in the CC.
Excellent. Usually we use it when we saw the asymmetry, or we saw the lesion in MLO not seen in the CC view. Okay, so if a lesion is seen only on MLO view, it may be obscured on the CC view or located posterior or lateral or high in the chest wall, as we described, as these areas are not well imaged on the CC view. So a 90-degree lateral projection, it allows localization of the lesion seen only on MLO based on the concept of triangulation when the nipples are aligned at the same vertical projections. If the asymmetry is maintained even after the angles of projection is changed, then additional view in the other projection should be obtained. Okay, so a slight shift in orientation of breast structure relative to the X-ray beam is sometimes or is often sufficient by the disappearance or change appearance of the asymmetry. Why? This change, if the asymmetry disappear, that means it is just a summation of breast tissue, and if it persists, that means it is real. If the lesion is real, the shift relative to background breast tissue between the two projections can separate unrelated superimposed structures and help localization of that lesions. This information can be used to guide positioning in the CC view to confirm the three-dimensional location of the lesion or the triangulations. And the anatomy of the woman, you see, orientations and strength of the pectoralis muscles, this might hinder, okay, the proper compressions of the breast on the MLO. When we put straight lateral, this it will help in more compressions and will allow us to differentiate if the lesion is there or not, and if it is real or not. It's okay. So what is going on here? This is asymmetry. The patient's 58-year-old woman follow up in a patient with history of ovarian cancer. What is going on here? Hint?
There is asymmetry which is seen in the medial aspect or inner aspect of the CC, but it's not seen in the MLO.
So how you are going to manage this patient?
I can use additional views, like when I see a lesion in the CC but not in the MLO, I can do rolling view, and I can do compression.
Okay. Okay. So can you consider it if you do spot magnifications view and you did not see it? You will consider it as birat. You will call it as birat. If it is not seen, if this patient,
yes,
you do spot and the lesion not seen. So you will call it as birat.
But she had a history of ovarian cancer.
Excellent, welcome. So here we have to consider the history. So we consider it a patient, risk patients, elevated risk. Okay, so we have to take it seriously. In this patient, I have to do further imaging. Okay, they have done what?
Compression, spot compression.
Spot
and
compression and
it is there. It is still there.
This spot compression and this one. This is the MLO and this.
Okay.
It is written here.
It is written, but I'm trying to pick the difference. Yeah, it's written lateral, but I cannot.
So when they said lateral, not mid, not oblique, just the lateral. So you expect even straight lateral in case of the lesion seen on MLO, not seen in CC. But even if the lesion is seen on CC, we can do straight lateral view.
Okay.
See, and in this case, they have done straight lateral that demonstrate the lesions, and spot compression demonstrate the lesion. So this lesion is real, is persisting. And even here on the spot giving appearance of a mass-like lesions. Okay, so it is tiny, so I have to proceed for
ultrasound.
Ultrasound. Okay, the working
here the image is evident on the lateral view and persists on spot compression view. But so now it becomes focal asymmetry rather than symmetry because it is seen on the lateral,
Okay.
not seen on the two views, CC and lateral view. Okay, so it is focal asymmetry, but ultrasound no findings. So
either we move to other imaging or follow up after 6 months or short interval.
I will not accept it from
We move to MRI or tomography.
either to go for other view, other modality, or to do
Biopsy.
biopsy using
Stereo.
yes, stereotactic. Yes. So stereotactic biopsy was performed and pathology it was ductal, invasive ductal carcinoma. The patient history, you have to consider the history. You should not say, I'm going to follow the patient. You want to pick the cancer as earliest as possible. And even for the CC view, not seen in MLO, is not a rule. You can do also straight lateral. You see, you might see it. Not seen here, but with some when you angulate, you make the difference in angles, you might see the lesions. Okay? And what about this? This 58-year-old patient screening mammogram. This is previous and this is current. So you have
Developing
asymmetry. So seen, it was not seen on CC view. It's a single scene only on MLO. So next it will be
also I will compression.
okay, compression. It is there.
Yeah, so it is.
I want to know where is that lesions. I'd like to know where is the lesions.
The lesion is in the apex of the fibroglandular tissue.
No, in the yes, it is the superior, but I would like to know, is it real?
Do lateral view.
Excellent. Abir?
Yes.
Yes, I will do straight lateral, 90 degree. Comparing, we said comparing the initial with the previous 1 year, it shows developing single view or one view asymmetry. Okay, I need to make sure it is just an asymmetry or focal asymmetry. I'll go for the straight lateral, and this is a straight lateral view. Tell me.
It is at the same level.
Is it at the same level? Sorry. Is it at the same level?
Higher. No.
It is at the higher level.
Yes, higher level. So it is medial in the CC.
Yes. Yeah. We make this the nipple at the vertical planes, and it is at a higher level, so expected to be in the medial breast. See? So confirmed by targeted ultrasound that it is in the medial and it was mixed ductal and lobular carcinoma, invasive ductal carcinoma. Okay. So as we described before, we said triangulations of the lesions using the straight lateral view for triangulations of asymmetry. This, if the lesions, this is the lesion here, okay? This the line represent the MLO, and this is the straight. When the lesion here on MLO and tracing on the straight, that means we are dealing with a medial breast lesion, as seen here, like in our case. I don't know why it was moving before I was put it correctly, these lines. But even like this, it's correctly. It is obviously, I mean, it is obviously this line is longer than this. You see, obviously this one it represents that it is a higher at a higher positions. But when you put the same vertical, the nipple at the same vertical positions, you will see the lesions here in the MLO, and here in the straight lateral is going up, is getting, it went up. You see, look it here, it went up. So that means it is on the medial aspect. This is the lesion on MLO, and on the straight lateral is going up. When do the SCC and the lesions found to be on the medial aspect, while here, this is the lesions, this is the MLO, on the straight lateral is going down. Here, this is the MLO, this is the lesions, here in the MLO, while in the straight is getting down. So when it's getting down, it is on the lateral view. This is the MLO, here in the straight lateral is going down. So it is seen, they will search for it on the medial on the lateral aspect. So the lesion, it will be laterally. And as we mentioned before, this, when we comparing the 90-degree lateral view to MLO, and the medial lesion will rise and the lateral lesion will fall, as illustrated by the mnemonic muffins rise and let fall or let sink. And the muffins reflecting for medial and let reflecting for lateral. And what do you think if the lesion is central? If the lesion is medial, it will rise. And if the lesion is lateral, it will fall or sink. Yeah. So, because the lead is heavy.
It will not change its position. It's central.
Huh?
If it is central, it will not change its position.
Excellent. Well done. Yes. If it is central and if it is not real, it will disappear. A lesion located centrally will not change the location between the 90-degree and lateral and medial and mediolateral view. Between 90-degree lateral and mediolateral, it will not show change in positions. Alas? And this difference in degree of obliquity between the 90-degree lateral and MLO views, it will help to determine the lesion. If it persists, that means it is real. If it is change or disappear, that means it is just summation artifacts. Okay? We have, sometimes you might do the 90-degree lateral and still you could not appreciate the lesions. How you can manage? If you put ultrasound and you could not see the lesions, and the CC, it doesn't show the lesions. You have seen it only on MLO view. And you want to make sure is it real or not. You need another view. Which is that view? Quickly. We want to go through the rest of the examples. Are you following, all of you?
Can you repeat the question?
Yes,
Tomosynthesis?
Yes, we are doing.
Okay, tomosynthesis now, yes, tomosynthesis. But before tomosynthesis, we have what we call it step oblique mammography. Step oblique. In the previous, from the oblique view, we shift to 90 degree. But if you shift to 90 degree, and still you could not see it, you can just shift just 15 degree oblique. From the mediolateral oblique, go to the site of the lesions, okay, and just do a step of 15 degree and just proceed like that. It might help you to visualize. We call it as a step oblique mammography. If the finding is not visible on step oblique, then it will represent a summation artifacts. Okay? If the findings are developing asymmetry or associated with suspicious findings, even if you did not see it, you have to do ultrasound or you have to proceed for biopsy. You should not ignore it. See? Okay. What about the rolled view? Do you know the rolled view?
Yes, if a lesion is seen in the CC, but not seen in the MLO, then we can do rolling of the breast around the nipple.
Excellent. Rolling of the breast around. How we do the rolled view? We just described before, but not in details. We describe it in the mammography positioning.
Yes, I remember in the same position of the CC, but just do a roll of the breast around the.
Yes, you are right. You are right. But if you have seen a lesion, okay, what is the significance? How it can help you? Do you know how it can help you?
I don't remember.
Okay, any volunteer? Anyone knows how rolled view it can help and how you can do it? Okay, as he mentioned, you will take the superior part of the breast and roll it to one side, around the nipple, around the axis of the nipple. Either to roll it medially or to roll it laterally. We can say medial rolled view, lateral rolled view. What is the significance of that? If I have a lesion in the superior breast, it will go
more medially.
If you are going laterally or medially. Okay, let us see the examples here. Okay, this is the medial roll view. On the CC view, you are going to move the breast. You will move the breast around the axis of the nipple. You will move it. You will roll it. If you have this represents a lesion at superior breast, and this represents a lesion at the inferior breast. If we are rolling the breast, usually the rolling, it will be the superior breast. We are rolling the superior breast. When we roll the superior breast medially, so anything in the superior will go medial while the inferior will go lateral. You got the point?
Yes.
The superior will go medially, while the inferior will go the reverse, will go laterally. If you roll the superior part of the breast laterally, anything superiorly, it will go with the tissue you are pushing. You are pushing laterally, so anything in the superior breast, it will go with you. It it will go lateral, while the inferior breast will go medial, will go the reverse. That reflect what? If you have a lesion in the superior breast and you rolled the breast medially, the lesion, it will go medial. If you roll the breast laterally, then the lesion, it will go lateral. But if you rolled medially and the lesion go laterally or the reverse, that means it is at inferior breast. You got it? If the lesion at the superior breast, it will go with your rolled tissue. If you roll it medially, it will go medial. If you roll it laterally, it will go laterally. But if you roll superior breast medially and the lesion go laterally, that means it is inferior breast, and the vice versa.
Okay.
Okay?
Okay.
Is it clear for all of you? Okay. So this is direction of roll. So this is in the superior breast. Here you are rolling lateral. Okay? If you are rolling laterally, look, the lesion, it will go with you lateral because at the superior breast. From the superior breast, it will go with you. It is in the medial here, the lesion in the medial, but you are rolling lateral. But because it is in the superior breast, it will go with you toward the lateral breast. Okay? But if the lesion is here, is inferiorly, and you roll like this, it will go medially. It will not go laterally. Is it clear? The direction of roll should be chosen. It should be chosen that the region in question is rolled toward and projected over an area of fat. As I described for the spot compression, okay? If you, while spot compression, let the lesion swept into a fatty area, it will help to clarify. Even here in the rolling, if you just roll toward the area of fat, it will help us to clarify the concern or the targeted lesions. Okay, so that lesion is not obscured by fibroglandular, and this requires preliminary assessment of fibroglandular pattern to avoid the erroneous conclusions that it has disappeared. It might roll it and get disappeared by if the breast is relatively dense. When you roll the lesions and just disappear by the fibroglandular tissue, it might give you wrong impression that the lesion disappear is not real. And that is why we are trying just to roll the lesions toward an area of fat, not to roll it toward an area of fibroglandular tissue. You got the point. And is not only that, as we mentioned, this roll, it is helpful to differentiate the real from superimposition of tissue. Is not only demonstrate the location of the lesions, but demonstrate also the lesion, is it superimposition of or just or a real lesion. Adding this example, if you look here, this is a lesion, this is an asymmetry. When rolled CC done, it disappears. In a case of just normal breast tissue, this demonstrate a superimposition of tissue. So it is appropriate manner cause summation shadow to be virtually disappear because of the relevant tissue will be displaced. Okay, so if the lesions in the upper part or superior part of the breast, it will roll with a rolling. If we rolled laterally, we'll go laterally. If we rolled medially, we'll go medially. If the lesion inferior part, it will go to the opposite side. If we roll the superior breast medially, the lesion will go laterally. If we roll the superior breast laterally, the inferior lesion will go medially. If the lesion at the center of the breast, what will happen? If it is at the center,
Will not change.
it will not change. It will not change. Okay, let us see this. This is an example. You have asymmetry here. Okay. Yani central toward the medial aspect of the breast. This rolled to which side? The breast here is rolled medial. Look here, look here. This breast is pushed toward the medial aspect. And this breast here is pushed toward the lateral aspect. From the breast, from the appearance, you could appreciate that it is going to which side. This is medial and this is lateral. So this lesion is superior or inferior?
Inferior. Superior, because it moves medially.
Because it moves medially. And
Well,
here
we rotate. Here we rotate the breast laterally and it moves laterally.
Yeah, it moves with the breast, as we mentioned. Usually the roll is the superior breast tissue. We are rolling the superior breast tissue. So if the lesion located superiorly, it will roll with the breast tissue. Here, when we roll the breast tissue medially, the lesion goes medially. When we roll the breast tissue laterally, the lesion goes laterally. So that lesion is at superior breast. See? So this is the localization is the superior breast since it moves. If it moves in the reverse, that means at the inferior breast. And that lesions, you see, these lesions, we said at the superior breast, confirmed here on MRI, located in the superior breast as enhancing lesions, and it was invasive. It was not shown on ultrasound. Target ultrasound could not be appreciated. Look how it is subtle, okay? And how it appreciated as enhancing small mass on the MRI, and MRI guided core biopsy revealed invasive ductal carcinoma. Okay. These lesions, this asymmetry, not seen on CC view, on MLO. So we can do here.
Straight
Yes.
lateral.
Yes, this it can be from here I can suspect. I could appreciate the medial, the posterior medial aspect, but part of the lateral aspect is being cut. So I can do straight lateral, or I can do, we described before, we can do, and usually on the CC view, what is the area expected to be not included is
Superior and lateral.
so I can do
Roll it.
yeah, I can do extended lateral. Yes, I can do extended lateral. I can do extended lateral. You see, this is a CC view. We said before, the extended lateral is the CC view. You see, but going more toward the lateral aspect, because here the extreme medial is seen, but the lateral is cut. And usually the lateral aspect is not visualized. I can just do extended lateral, and here the asymmetry is confirmed to be real. It is a focal asymmetry rather than just asymmetry. And this is the MRI here demonstrate enhancing lesions, and core biopsy demonstrate ductal carcinoma. Okay. So we almost go through the additional mammographic view. Then also ultrasound develop or plays important role in evaluations. This is a lesion here, area of asymmetry. This is a spot compression. It's even become more subtle, but I can see faintly asymmetry here. And the straight lateral, same as the spot compression. Apparent effacement. It is a developing when view asymmetry. So what is next in a developing? Even is getting what? As if it is effacing, as if it is just normal tissue. But remember, it is a developing asymmetry. I have to consider it. I have to consider it.
Ultrasound.
Yes. Ultrasound at that time, this one of the missing cases. At that time, they did not do ultrasound, but because of dense breast, they recommend 6 months follow-up. But after 1 month, the patient presented with palpable abnormality and look for the ultrasound. Demonstrate an irregular indistinct mass. Biopsy was done, and it was invasive ductal carcinoma. See, and this is straight lateral performed after biopsy. Demonstrate the clip, post biopsy clip is within the corresponding area of developing asymmetry. Okay, here another example. There is focal area of asymmetry. So what is next?
Compression.
Compression. Demonstrate the same.
Okay, ultrasound.
Ultrasound. Look for ultrasound. So look for the difference. Here, not very impressive, but look for the ultrasound. Is speculated or angular, indistinct, heterogeneous, hypoechoic with ductal extension. So it is BIRAT 5. It become BIRAT 5. After ultrasound, it's become BIRAT 5, and it was invasive ductal carcinoma. Okay, and this case of, look here, this is the area of asymmetry. Compression view, spot compression spread away the surrounding tissue to reveal underlying small circumscribed oval mass. Ultrasound revealed that mass is just a cyst, so downgrade the lesion to BIRAT 2. And in this case, here, this is 2015, this is 14, and this is 15. So we are dealing with, in screening mammography, we are dealing with
Developing asymmetry.
Developing asymmetry. Look for the ultrasound.
Show irregular mass with angular margin and posterior acoustic and posterior shadowing.
Yes, indistinct lesions with posterior shadowing. It will be BIRAT
5
or C. Not typical like that one. It can be, just it will go for 4C. It is BIRAT 4C, and it was grade 1 ductal infiltrating carcinoma. Okay, so this is 51-year-old lady with history of car accident earlier, and she had this, you see, one view developing asymmetry. So the previous, it doesn't show. Being just abutting the chest wall, it might just be not excluded, you see, from the field of view in the other view. So what is next?
Compression view, spot compression view.
This is a spot compression view. The lesion is there. So what is next?
Ultrasound. You have to do an ultrasound.
Okay. Is it asymmetry or focal asymmetry? So since it does not spread away, I need to make sure it is three-dimensional. It is seen in other view, different angles. So, okay, this is the ultrasound. You ask for ultrasound. What about ultrasound? What is your impression from ultrasound? Indistinct hyperechoic mass. Though history and appearance going with history and appearance are suggesting of fat necrosis, but I will go for biopsy, either follow-up or biopsy, since it is not very typical, or I'll go for MRI to confirm that it contains fats. But they had done, I think they had done biopsy after targeted ultrasound to confirm correlation with mammographic asymmetry 90-degree, showed biopsy clip. Yes, they had done biopsy. You see, and this contained the biopsy clip, and this is the BB. You see, confirmed that the biopsy is taken, the biopsy based on ultrasound, taken under ultrasound, and they put the clip to make sure the biopsy is taken from the same asymmetric findings. So, ultrasound guided biopsy revealed a fat necrosis. Okay, so what is going on here? This is MLO, 2 MLO, and this is CCVU. This is previous and now. So we are dealing with
Developing
asymmetry. And developing asymmetry, very clear, very obvious. Okay, ultrasound demonstrate hypoechoic mass. It was assessed as BIRAT 4C and confirmed to be ductal carcinoma. This is the ultrasound, microlobulated, you see, microlobulated, and here there is ductal extensions. This is but not clear. If it is confirmed, if it is larger than this, it will be BIRAT 5, but can be BIRAT, as we mentioned before, microlobulations is BIRAT 4C. Okay, so this ultrasound is helping us. What about this? This lady presented with palpable abnormality. Ultrasound mammogram demonstrate focal asymmetry. And this is ultrasound here, demonstrate this heterogeneous area, biopsy performed, and the result was granulomatous mastitis. Heterogeneous tubular hypoechoic structures, or biopsy it was granulomatous mastitis. Okay, so ultrasound helping us. And what about this? This is old lady. She has asymmetry, seen on MLO, not seen on CCVU. Persists on spot compression. This is the ultrasound. So, what is next? What should be the next?
Biopsy.
Why biopsy? Excellent. Why biopsy?
As its ultrasound showed hyperechoic mass in a tubular configuration.
Since it is palpable abnormality, an ultrasound area is just heterogeneous, not very clear, and she's old, she has palpable abnormality, we have to proceed, okay, for biopsy, and it was a Malta lymphoma, CMLAT lymphoma, the core biopsy result. Okay, so asymmetry seen on one projections, as we mentioned, if it is not summations artifact, the probability of being malignant is 10%, even more than the focal asymmetry. Okay, so this patient, she has focal asymmetry on screening, mammography in the lower inner, on spot magnification, even it appear a little bit irregular and with some speculations. And ultrasound demonstrate 5 millimeter nodule. See, just after biopsy, a needle was placed in the nodule under ultrasound control. You see, they put the needle wide, and they had done lateral, straight lateral view. Why? To confirm that the biopsy, the area being biopsied is that nodule. It might be another area. To confirm the biopsy taken from the corresponding asymmetry, and here the asymmetry from the mediolateral to lateral through lateral view is just a little bit superior. Look, is a superior here. It is in the lower quadrant, and here going toward the central quadrant, a little bit higher because it is on the medial aspect. Okay, and this example of a patient, they had taken biopsy for the asymmetry and look for this circle representing the post biopsy clip, which it looks lateral to the side of the asymmetry. On the follow-up, the asymmetry was increasing in size, and the post-biopsy clip is far away from it, and surgical excision revealed invasive mucinous carcinoma. We mentioned before, mucinous one of the causes of asymmetries. So, after image-guided large core needle biopsy, the evaluation is not complete until pathologic findings are reviewed and should be concordance with the imaging findings. Discordant pathological findings after tissue sampling should prompt consideration to repeat biopsy and possible surgical excision. You got it? Okay, so we finish ultrasound, go to digital breast tomosynthesis. As you know, digital breast tomosynthesis is recently incorporated and proven very helpful, improving both sensitivity as well as specificity. It improves the visibility of asymmetries and its characterizations. Okay? And demonstrate if it is associated with underlying mass arterial distortion or so on. In this case, in these examples, this is the 2D and this is the tomosynthesis, reveal that this asymmetry is just summation artifacts. Okay, this is an example of focal asymmetry on the left outer quadrants, you see here, and barely seen on a spot compressions, okay, barely visible, but look for the tomosynthesis revealed that the focal asymmetry and look for the spot compression of tomosynthesis, demonstrate 3 millimeter lesions, speculated lesion, and it was not seen on ultrasound. Stereotactic core biopsy revealed ductal infiltrating carcinoma. Again, if you look here, there is suggestion of focal or asymmetric findings on mammography here. It was seen on the CC view. That is why reported as focal asymmetry. But look for the tomosynthesis, how it clarified as a speculated mass, and demonstrate another lesion which was not appreciated on 2Ds. And core biopsy revealed multicentric infiltrative ductal carcinoma. Okay, what about the breast magnetic resonance imaging? It has been shown to be helpful problem solving tool after complete diagnostic mammographic and ultrasound workup for inconclusive or equivocal lesions. We should not just see a developing asymmetry or focal asymmetry without doing spot compression or doing other views, mammographic views, not doing ultrasound, jumping directly to MRI. We have to complete the whole workup, and then if we need going to MRI, and this is an examples. Here the spot compression demonstrate the area of asymmetry as persistent. Findings in a 52-year-old, it was not seen on MLO or on 90 degrees, seen only on the CC view. So it is seen in a single view, and diagnostic and also was not seen on targeted ultrasound. So here we need to confirm by MRI, because it is really impressive as a mass on the spot compression view, giving the conspicuity of a mass, but being seen only on a CC view and a spot compression view, we need to solve the problem by doing MRI, and this is the axial and sagittal post contrast revealed the lesion here as irregular enhancing mass. Okay. Also, second look ultrasound showed no correlate, and then use the ultrasound as guidance to take a biopsy, and the result was infiltrative ductal carcinoma with carcinoma in situ. And in this patient here, there is area of developing asymmetry, you see, and the MRI demonstrate a non-enhancing area of fibroglandular parenchyma here, for which just follow the lesions by mammography and reveal regressions of that area of island of breast tissue in a short-term follow-up MLO, 6 months follow-up, I mean. So it confirmed just a benign process. Okay. This is another example. I don't know why they proceed for MRI. There is area of asymmetry. Ultrasound is clearly demonstrated irregular suspicious mass here, but still they have done MRI and demonstrate irregular enhancing mass. Pathology revealed ductal infiltrative carcinoma. Okay, it is important to compare with the previous mammography as we described before, and in this case, mammography show focal asymmetry. Additional mammographic view and the straight lateral view showed the asymmetry as arrows. See, so we have to go for the previous mammogram available for comparison. It was obtained 2 years previously and obtained 4 years previously. We have 2 years and we have even 4 years previously, and this focal asymmetry It was stable for the 4 years, so it will be BIRAT 2. If you look here, look for it. It looks like a mass. It looks like an irregular speculated, but it was stable for 4 years, so that it will code it as BIRAT 2. So when previous mammograms are available for comparison and demonstration of short-term, the demonstration of short-term 1 year stability eliminate the need for 6 months follow-up. Would you please close your mic? There is child crying, please. Okay. Would you please mute your mic? Okay, we said if we have previous mammography and the lesion is stable for 1 year, no need to do 6 months follow-up. We are going to do 1 year, okay? And until 2 years stability is required to say this lesion is benign findings. Also, demonstration of lesion stability for at least 2 years or demonstration of lesion regression, this is justifies a definite benign assessment by RAT 2. If no previous mammogram are available for comparison, or non-palpable focal asymmetry are often assessed as probably benign by RAT 3 with recommendation of periodic mammogram surveillance about short-term follow-up at 6 months, then 1 year and 2 years before returning to screening. Okay. Who is going to take this example, this case? Any volunteer?
I will take it, Dr. Rabab.
Okay, you're welcome.
Okay. Okay. At the left, at the left breast, the lower inner quadrant, posteriorly, there is a mass. Okay. Irregular.
Excellent. Well done. Huh?
Okay. Hyperdense.
Okay.
Okay. With the lobulated. Okay, lobulated outlines. Okay. No. Okay. There is another area of okay, asymmetry.
Excellent.
I can. Okay.
Asymmetry or focal asymmetry?
I can see it just in one view.
Okay.
I try to appreciate it in the MLO, but I see it in CC view. Okay.
Okay.
I see it in CC view almost, and at the outer. Okay. Okay. No other abnormality. Okay.
What is next? Okay. What is next?
Okay. Next, I want to have a spot compression of the asymmetry.
Okay. So this is the area of palpable abnormality.
Okay.
Now,
for
can
better assessment.
you see what is the other? What about the other? What about the other asymmetry? Is it asymmetry or focal asymmetry?
Other one.
You are talking about this one?
Yes, this one at the CC view.
And
at the
MLO, you put.
Maybe I think of the upper.
Yes, it is the one. Yeah,
here,
it is here. So it is you
okay.
are dealing with
so
focal.
It's area of focal asymmetry.
So
yes.
any additional findings? Yes, you said you from the beginning describe it. So is it significant or not significant, this focal asymmetry? What is the significance for this?
Yes, it is significant. Yes.
Why? Why
it could represent Okay, because we have a palpable abnormality with this mass, so I'm thinking about multifocal. Yes, it could be
Multifocal, and if it is another lesion, it will be multifocal or multicentric. Okay, so this is the lesions. This is the other. This is the down the palpable abnormality, while this is the next. This is the other lesions. Next step, as you describe, we'll go for the spot. So this is the other one. Okay. The spot magnification on CC, and this is the on MLO. This is the MLO.
Yes,
you see, if you look here, this one.
Yes.
And this one, this is the CC view. This is the CC view, and this is the MLO. Okay. So you are dealing with.
Okay. So in the MLO, I think yes, it is mass speculated outlines.
Speculated with even classification.
Additional features.
Yeah. Yes.
I cannot see
Here it is part. It's cut, but this is even these are two. And this is the same. You see, if you look here, this one is far from this one. It is far from it. So this one is not the index one. This is not the index. This is a small lesion itself. It demonstrates even the small area, represent multiple areas, multiple suspicious areas. This and this is if satellite, and here. So we are dealing with
multicentric.
What is the difference between multifocal and multicentric?
Breast.
The difference between multicentric and multifocal.
Multifocal, usually it will be, yes, multifocal within the same quadrant.
Excellent.
Or less than 5 centimeters between the two lesions.
Excellent. Within 5 centimeters from the index lesion or same quadrant. If it is in different quadrants or more than the distance, more than 5, it will be multicentric. And what is the impact on the clinical, on the management of the patients?
Yes, it will change, and it will not be just if they will treat it. Most likely they will go for extensive management. Complete, as mastectomy and like that instead of quadrectomy or just lumpectomy.
Yes. So the presence of multicentric disease, it will make the conservative not the wide local excisions, or the, you call it what, not non-mastectomy treatment is not an optional. You see, it will not optional. Then they have to go
lumpectomy or
they have to go conservative. I was looking for conservative treatment.
Hello.
It is conservative treatment. The wide local excision, the other name is
breast conservative.
Yes, I don't know why I get confused. I was saying conservative, but I get confused. Yes, breast conservative treatment, it will not be an option of treatment if there is multicentric disease. So it is important. The disease existence is really important. Okay, this is multicentric and contraindication for conservative treatment. Okay, this is another patient. Quickly. Would like to go quickly. عبير، سهير، هند، مجدولين today ما في مدينة مجد.
This is lateral and craniocaudal view of the right breast, showing ill-defined and asymmetry as a right breast on the medial.
It's okay. When we are talking about asymmetry, just you will say That
Asymmetry.
is asymmetry. If you are talking about the mass, you'll describe by further.
Sorry.
If you are talking about the asymmetry, just will describe which type of asymmetry if it is clear. If it is either asymmetry, or if you start, you can say asymmetric findings, mammographic findings seen in only one view, or like that, corresponding with asymmetry or with focal asymmetry or with developing asymmetry, then you can classify it further. But you are not going to say it is an ill-defined, since it is not characterizing given the criteria of the mass, so it is just asymmetry. And you have,
Sorry,
to
I'm
consider,
confused.
you have to consider the clinical history. A 65-year-old woman attended for the screening mammography with no palpable lump reported and no recent clinical breast examination performed. Okay, and look here, this is a second round screening mammography. So how you are going to manage this patient?
This is the, represent developing asymmetry as a medial part of the breast, of the right breast. And
Why you said developing asymmetry?
because this is a second screening mammogram.
I did not mention the previous was normal.
With no palpable lump reported.
Yes.
Sorry, in the
Palpable.
history.
This is
Sorry,
history.
history, yes, in the history.
So,
So this is asymmetry at the medial part of the right breast.
medial,
Inner part of the breast.
you are talking about this or you are talking about this?
Sorry, lateral part of the breast, outer.
Outer, superior, outer.
Superior outer on craniocaudal view.
It's not this one. It's okay. So you could not appreciate it in the other part, in the other projections. We are talking about one projections.
Yes.
Okay.
I think this is represent focal asymmetry. So
Where?
I have to
Where you
compression.
have to concentrate. Is it focal asymmetry or asymmetry? What is the difference?
Focal asymmetry, but I need compression. Spot compression.
What is the difference between focal asymmetry and asymmetry?
Asymmetry on one view.
Okay.
Seeing on one view. Focal
Okay.
asymmetry, you have to see in two views, more than one
And
view.
here at the beginning, you said you could appreciate it only on CC view. And you said it is a focal asymmetry. So it is seen on two views or only one view?
I'm suspicious about mediolateral
It's
view.
okay. So you are suspecting this is to be a focal asymmetry. Probably appreciated. So what is next?
You have to do compression, spot compression view.
Okay. Or yes,
or
we'll go.
Or ultrasound.
You did not. I mentioned for you this is a second round screening mammography. So
you have to do another view like lateral, dead lateral.
You don't like to see the previous?
Yes.
Yes, you have a small non-specific area, asymmetric findings in the upper outer quadrant of the right breast. So this is a spot.
Compression view.
Done for
Confirm.
you.
This is confirm the focal asymmetry.
In both MLO and CC. So you are dealing with?
This is suspicious. This is suspicious.
You are dealing with
focal asymmetry.
Confirm for you this is a focal asymmetry because it is seen on both spot magnification on both lateral as well as CC. So you have seen it in two views, two projections. Confirm it is real findings. It is real findings, but still these real findings Is it associated with distortion? Is it associated with mass? Is it a mass?
No, it's just unfocal asymmetry confirmed.
It still doesn't show the conspicuity of a mass. We have seen many examples. The spot compression demonstrate the focal asymmetry to represent a mass on spot compression. But this looks still same as on the standard view, just it does not spread away. It is seen as a focal asymmetry. Since it can be appreciated on CC as well as on MLO. So we are dealing with focal asymmetry. What is next?
You have to do an ultrasound.
If I could not see it on ultrasound.
Another examination like MRI.
I want to know, is it stable? Is it developing asymmetry? I was you see, pointing for you many times. Here I told you second round screening.
Yes, you have to do to see the previous images.
You have to, and we mentioned before, just we finish, okay, discussion about the importance of previous mammography. We should compare with the previous. We should always ask about the previous mammography.
Yes.
It's not in the system, and we have told the patient always to keep her mammography with her. And if she's coming for new study, she has to bring her all previous mammography with her. So we need to compare it with the previous. That was the first round. First round screening mammography.
This is craniocaudal and mediolateral and craniocaudal view of the skin of the right breast, showing an asymmetry.
That your asymmetry here? Could you appreciate it here? Look for this asymmetry.
Yes.
Concentrate on it. Could you appreciate it here?
I couldn't see the previous image.
Yeah, so it is now
developing asymmetry.
Yeah, so you are dealing with a developing asymmetry. Okay, you are dealing with a developing asymmetry. So they did not do at that time. They did not do ultrasound. They did not do. They just let the patient go for the third round. Just they pass it like that as something not significant, and the patient came for the third round screening mammography.
On the third mammogram, the previously seen focal asymmetry, now it is increasing size and being more speculated with more ductal extension to the nipple. So it increase in size. So the focal asymmetry now representing mass, speculated mass.
You cannot say a mass. It is focal asymmetry, but it's associated with some distortions. See, because I brought for you the spot compression at the same moment. You did not. I did not. And I kept it from you. I present for you the standard as well as the spot compression at the same moment. I could not well appreciate. Might be.
Become denser, more denser, and
might be, but not very well conspicuity of the mass. Yes, here in this view might give some impression of more focalized. It might be a mass, but there is some distortion in the area, and that I have to go for
ultrasound.
For ultrasound, and this is ultrasound.
Ultrasound show an ill-defined, irregular, mixed echogenicity mass with increased vascularity and cutting sign. Cutting sign. I see cutting sign here. at the right lower part of the mass.
I did not see cutting sign, but from this is enough. Being heterogeneous, being
Hypervascularity
there
represent
is moderate vascular intralesion vascular signals and indistinct irregular is enough. Just I will make it BIRAT.
BIRAT 5.
I will go for BIRAT 4C.
4.
Don't know. And for me, I'll go. I don't know. This is from literature. Really, I don't know how they describe it. But for me, I will put it as BIRAT 4C for biopsy. And let us see. Okay. On the next screening mammogram, 1 year later, it represents more prominent, but otherwise similar. As we mentioned, it is still focal asymmetry, but is more prominent. However, on occasion, target ultrasound shows small, mildly vascular hypoechoic mass measuring about 1.3 by 1.2 by 0.8 centimeter and underwent ultrasound guided biopsy. The result was grade 2 invasive ductal carcinoma. See, so we have to be cautious. If you got this, yes. If we have subtle lesion like this, okay, we have to look for the previous, and if it is developing asymmetry, we have to do ultrasound and we have to go further, not just to pass it. Okay, Hannah, are you there? Heidi is not available today, and Medina and those. Okay, Hannah is there?
أهلا أيوة موجودة يا رباب.
This is for you.
Okay.
Rabnaoff today is not available. I did not hear her voice. Okay, Hannah, go ahead.
So this is an midulateral and CCU views. On the left side, there is an global asymmetry. At the same time, as technique, maybe it's not as symmetrical or something on technique.
Okay, suboptimal. Yes, agree. It is suboptimal, but there is left.
Yes,
left
on the
global
left,
asymmetry.
Global asymmetry.
Okay. What is next?
The next is ultrasound.
Okay. And okay. Okay. So there is language barrier. It is important because we have to ask about history, but as they mentioned, there is language barrier. So this is the ultrasound.
Ultrasound shows there is large heterogeneous hypoechoic and hyperechoic mass with area of indistinct margin and area of micro lobulation. So from this lesion, which is deeply, I will go for PIRAT 5 or 4C for biopsy.
I'll go for 4C.
4C biopsy.
Pure biopsy. Why? Why I'll go for 4C? The skin was red and indurated and tender to touch.
Yeah, this is coming later. Yes, there is a sign, there is signs of skin changes. So
So
I will
history, this
from this
clinical might give impression of
of carcinoma, because skin is red, tender and red.
Tender skin, tender to touch. Yeah, red, indurated, tender to touch, is sign of
inflammation. This sign
inflammation. Sign of
yes.
So that is why I said it might be. Yani, I will not go for Birat 5. I'll go for Birat 4C.
Yes.
Since it can be the differential might include benign, inflammatory. It can be mastitis.
Yes.
It can be just mastitis. It can be carcinoma. It can be mastitis. So the differential diagnosis, it can be inflammatory carcinoma. It can be mastitis. Okay. And depending on the clinical history, the patient receive antibiotic and follow-up mammogram. Okay. And ultrasound guided biopsy revealed malignancy. Sometimes malignancy associated with superadded infections, complicated by, and rarely malignancy can be presented as an infection and even an abscess. I have one patient. I'll try to find it from my collections. It was so much interesting that the patient have just presented with breast abscess. See, and we discussed the case and decided just to be taken surgically, and the result turned out to be an invasive cancer. And the patient, if I remember, was lactating even. One of the rare presentations of breast cancer, just an abscess. It was an abscess. Okay.
Okay.
Yalla. Abir.
Yes,
Abir.
Dr.
Yes, this for you.
Yes, welcome.
Okay.
MLO and CC view showed hyperdense mass, hyperdense speculated mass.
Excellent. Hyperdense speculated mass in the
upper outer quadrant.
Outer posterior left breast.
Yes.
Upper outer posterior. Oh, okay. So
there is no associated skin thickening or calcification.
yeah, but it is not very clear, the skin here and this. So yes, even not necessarily. Not necessarily. It is Birat.
From here it is Birat 4C. As
Why?
Speculated.
Speculated it will be Birat
5.
Birat 5.
Sorry.
You forget?
Birat 5, yes.
This is Birat 5.
Birat 5.
Okay. So Birat 5. This is Birat 5. But what is the significance? So from imaging, we need to stage. Yeah? We need to do staging. What are the staging? We have to do it. We want to know, is it single or multiple lesions or associated with invasions of the chest wall, invasion of skin, invasion of nipple, axillary, contralateral breast, and all these are important from imaging. Huh? So
in the MLO, it appears that some ductal extension toward the nipple.
Okay. Huh? Okay. Can you see any other abnormality?
And pectoralis extension for pectoralis.
Suboptimal. This is very suboptimal study. But there is another abnormality. Can you see other abnormality? And very important. And definitely these lectures or this talk is about asymmetry.
Yes, there
So,
is another
and this,
in the contralateral breast. There is an area of focal asymmetry
where
in the upper in the MLO in the upper quadrant. I cannot appreciate it in the CC view in the
you are
right
talking
side.
about this,
Yes.
this.
Yes.
This is normal fibroglandular, spread away on the CC view.
Can I help her? I think there is
Yes.
a
Yes, welcome.
small lesion within the right breast posteriorly.
Excellent. Inner posterior. This one, huh? Okay.
Okay.
Is it, how we describe this one?
It's an area of asymmetry as it's not appreciated in the other view.
It is not seen in the other view.
Yes, I
Right,
think so.
there is the same line. We said if you have seen a lesion, go from the nipple. If you draw the line like this, so you need to go at the same line. Take the same line from here.
Yes,
From
a bit
here.
in the lower part, yes.
Yes.
Posteriorly.
So
it's an area of focal asymmetry.
Yes, so this is focal asymmetry. Yes, here we appreciated this is a mass, and there is another area of focal asymmetry in the contralateral breast, which is very important. What is next?
Ultrasound for both breasts.
Posterior breast. So before ultrasound. Yes.
Spot compression view.
Yes. So this is a spot compression and ultrasound for the speculated mass. Look here. This is the one. Okay. And this is the spot of the contralateral, the posterior lesions, the focal asymmetry. The spot demonstrates that it is an indistinct mass, giving a conspicuity of the mass, and confirm on ultrasound as an irregular, indistinct heterogeneous hypoechoic mass, and both are malignancy representing synchronous contralateral metastasis. Is it common? The patient, she had contralateral metastasis at the same presentation. Is it common? Abir?
Yes, it's not common, but
no, it is unusual. It is only occurring in 1 to 2%. Okay.
Okay.
Okay. Who is there? Who is available? Heidi, are you there? Darelma, hint.
Sorry, there is an area of asymmetry.
You did not read the history. It is important to read the history.
Palpable abnormality, right breast.
So, where the palpable abnormality?
In the right breast, in the central, I can see it in the CC.
Where is the palpable abnormality hint?
In the right breast.
Right breast where?
I can see in the CC view. In the central area, in the mid-third of the breast.
I'm talking about the clinical.
There is dense marker.
No, you have a BB, you forget again. That is why.
What? Sorry?
You have a BB marker.
دي أنا بغششها يا دكتور رباب دي أنا هنا.
That is why I was insisted to look at the marker. You are always have problem with the BB marker hint.
MLO, yes.
You see, on MLO and in the CC even, you see?
The CC, I cannot see it.
That is the one on the CC. and here on MLO, so that reflecting the area of
The palpable mass. Okay.
the palpable abnormality. So the palpable abnormality in the
Is in
upper
the
outer,
in the upper outer.
upper outer. So look at this location for any abnormality. Could you see any abnormality?
And the CC, yes, I can see it. Is outer. Yeah, comparing it with the left, yes.
What you could see?
I can see an added fibroglandular density in that. Yeah. But in the
By now,
MLO,
hint. By now, would like to have the ACR descriptor.
yes. So it is asymmetry because I cannot appreciate it in the MLO.
I could see, you might say, I can see an asymmetric findings might represent, since I could not see it in the other, might represent an asymmetry. Okay?
Yes.
I would like to confirm it by spot compression view. We would like to be more precise in our descriptions. Okay? So
and yes.
So this is a spot compression. Could you see the asymmetry there? Is this persistent?
No, there is spread of normal breast tissue.
So, but if you look for the breast itself is extremely dense and nodular type of the breast. So expect it to have underlying fibrocystic changes, this type of the breast. And being there is palpable abnormality, what should be the next?
Ultrasound.
Yes, I should go for ultrasound, analyze the patient to target the area of palpable abnormality and to look. This is ultrasound. What about ultrasound?
So there are multiple cysts. One of them.
Multiple cysts where? So this is the upper, this is the upper outer right breast. So most likely this is corresponding to the site of palpable abnormality, the largest cyst. Okay? Okay. So how you are going to manage this patient? What is Birats? You are going to give Birats?
For the fibrocystic, 3.
You will give Pyra 3?
I think fibrocystic breast by 1 until there is lesion, yani.
I'm giving you multiple lesions. Give me Pyrats for these lesions.
So the first law, the upper law, they are simple, but the lower law, especially the last one, is
last right or left? Lower right or left or central or middle? Yalla, quickly, the time is over.
This one is the one you are pointing at.
What about this one?
It is complex. It's not a simple
complex. So this is complex. So it should be Birat
4. Yes.
4. Complex is Birat 4. We said simple is Birat 2. Complicated is Birat 3. And complex is Birat 4. So this is the left breast. The right breast are Birat 2. But the left breast is Birat 4. So the patient, multiple simple breast, but left upper outer complex cyst is 6 patient, it will be Birat 4. Okay, just to review what we have said, the entities including the differential diagnosis of asymmetry, if it is benign, the common summation artifact normal variant, including asymmetric breast tissue or hormonal changes, fibrocystic changes, pseudoangiomatous stromal hyperplasia, inflammatory, diabetic mastopathy, and granulomatous mastitis or fat necrosis hematoma. If it is malignant, invasive ductal lobular or mixed DCIS, lymphoma, and rarely the mucinous and tubular carcinoma. And yes, asymmetries, if it is seen, yes, asymmetries, if it is seen in one projection, it will be
Asymmetry.
asymmetry. And if it is seen in two projection, it will be
Focal asymmetry, global asymmetry, developing asymmetry.
okay. So yeah, just a reminder that not all cancer present with the typical features of malignancy, and we have 5% of invasive cancer were identified with asymmetry, and asymmetry is more weakly associated with cancer in screening examination than mass calcification and architectural distortions. However, asymmetries account for 6% of non-palpable screen detected cancer, but represent 27% of missed cancers, and is the second commonest, most common cause of false negative screening recall assessment. An asymmetry that has been stable for at least several years is unlikely to be significant. Okay, not 4. Mammographic asymmetries frequently resemble normal fibroglandular tissue, having interspersed fat and lacking convex margins. So the latter are the criteria for the mass. However, if a potential mass is seen in only one projection, it should be called as an asymmetry until it is three-dimensional characters is confirmed. Okay. The BIRAD 5th edition characterize asymmetries occupying less than one quadrant according to visualization on one or more projections and the presence or absence of interval changes, as you know. Or if it is just if it is changed, it will be developing asymmetry, and it is a new one. If it is seen, if it is occupying, if it is diffuse, occupying a quadrant or so, we call it as a global asymmetry, and historically we said it was asymmetric breast tissue, but no, but now it should be just global asymmetry. If it is less than one quadrant or focal, more focalized, we call it as focal asymmetry, and previously was called as focal asymmetric density. But as they mentioned, confused with the descriptor of the X-ray attenuation of the mass. And if an asymmetry is only seen as a single projection, they previously called as density seen in a single projection, and now called as one view asymmetry or an asymmetry. So just remind you, by developing asymmetry, uncommon findings becoming it's focal asymmetry, new, larger, or more conspicuous than previous, but we have to remember that can be seen in only one view, not always seen in two views, and it has undergone suspicious changes, and therefore most likely to be malignant. About 13, or the most type of asymmetry that having malignant potentials, okay, representing 13% of screening and 25% of diagnostic mammogram, both invasive as well as the CIS. That is why we should always take it in account, and we have to clarify and make sure that it is not signify or not representing cancer. So these cases warrant further imaging evaluation and biopsy unless found that characteristically benign, like simple cyst at ultrasound and diagnostic mammography form the foundation of diagnostic evaluation and begin with additional spot compression, lateral and rolled view as we described, and ultrasound is negative in 25% and should not exclude biopsy. When sign is identified on screening or diagnostic, the likelihood of malignancy is sufficiently high to justify recall for further evaluation and biopsy. Though over half of developing asymmetry are explained by summation artifact, which resolve on diagnostic evaluation, we have to, as we described that, we have to consider it as suspicious and to make sure there is no underlying malignancy. Benign causes that may be suggested by patient history include hormonal replacement therapy, trauma, surgery, and mastitis. Just revision for the practical workup algorithm for characterization and management of asymmetry. As we mentioned, asymmetric findings, we have to look if it is single or two views. If it is no, that means it's asymmetry. If it's sufficiently anterior to the chest wall in fatty breast, yes, that means it is summation shadow. If it is not, so we need to do additional view. If the additional view is summation shadow, that means it is category 1. If it is not summation shadow, we have to do triangulations and characterizations. If the lesions, if the asymmetry is seen on prior imaging, and the prior imaging are available, so we have to look for if it is new, larger, or denser. If it is yes, we have to ask for hormonal treatment, weight loss, history of surgery, trauma. If it is no, then it will be developing asymmetry and it will be Barat 4. If it is no, then we have to look if it is one quadrant evolved or less. If it is yes, one quadrant, so it will, if it is less than one quadrant, it will be focal asymmetry. And then we have to look for any associated masses or palpable abnormality or suspicious calcification or distortion. If it is no, that means it might be just an island of breast tissue or on closer inspections. If it is no, additional imaging. If it is associated with these findings, also we have to go for additional findings. And then if it is true lesions, we have to go for triangulations and characterizations. If it is more than one quadrant, it will be global asymmetry. Then I have to look for any associated abnormality or palpable abnormality, associated suspicious mammographic abnormality or palpable abnormality. If it is not there, it will be BIRAT 2. If it is there, I will go for additional findings and I will follow. If it is true lesions, I will go for triangulations and characterizations. And if it is no, I will go for category 2. And if it is stable for more than 2 years, then it will be just BIRAT 2. If it is not stable, it will still be BIRAT asymmetry. What is this? What does it represent? This method?
The arc method.
For what? For what?
For calculation of asymmetry. Yani,
Yes. To confirm
the expected location of the lesion.
Yeah, expected asymmetry in the other view. Okay. What about this one? This here, this is CC, this is CC, this is Briar, CC Briar, and this CC, this is MLO, and this is MLO. So
developing.
what is next?
Compression.
Spot compression.
Confirm
Confirm
the asymmetry, the developing asymmetry.
The developing asymmetry. So next,
ultrasound.
Ultrasound, demonstrate.
And MS speculated.
Okay, so next.
Biopsy.
And revealed infiltrating lobular carcinoma. This routine 2D CC demonstrate developing one view asymmetry. Developing one view asymmetry in the central breast. What is next? In old lady, dense breast, what is next?
Compression.
Compression. Okay. If it is not seen in compression,
ultrasound.
If it is not seen in ultrasound,
ask about history of taking any hormone replacement therapy or
no
trauma or
hormonal
infection.
replacement therapy, no infections. Okay, not seen on ultrasound. If it is not seen on ultrasound,
I need to have
more
additional
helpful, and it is difficult on ultrasound, but we have to do ultrasound. Before ultrasound, we can do
tomosynthesis.
Excellent, tomosynthesis. This is tomosynthesis. This is a tomosynthesis revealed the and localized the lesion. That means it is real, that it is a mass, demonstrated as a mass. And this is the target ultrasound revealed a suspicious mass. And this is the post biopsy clip ribbon shape markers. Reveal that it is within the lesion itself and representing invasive ductal carcinoma. What is BIRAT in this case? Can you see an abnormality here?
It's look like fibroglandular, fibrocystic breast or dense breast, something like that.
Can you see an abnormality? Anyone see?
Fat density lesion. There is a fat density lesion.
We're talking about asymmetries. We are talking today about asymmetry. Can you see any asymmetry? There are multifocal asymmetries here. Can you see it? So these multifocal asymmetry are seen here on, you see, I don't know, it should be this is BIRAT 0 on mammography and BIRAT 2
an ultrasound.
After ultrasound. Okay. What is BIRAT here? Okay. What is Birat? What is Birat? This one. Can you see an abnormality here? Can you see any focal asymmetry or asymmetry? Okay. Can you see it now? There is asymmetry here, and now it is seen as what? Here I can say this is Barat 0 because I could not see it in the other projection. Here, can I say this is focal asymmetry? Hind, Sarah, Hannah, how you describe this one? What is the description for this? And even you have seen this case before.
The first image, it is previous one. If it is previous one, and the second is the second scan, so it could be a developing asymmetry.
No, this is the CC and MLO. No, this is different projections. Only different projections. Yes, you are right. You are right. You are right. This is MLO. This is earlier, and this is yes. This is earlier, and this is new. But this is before you see. Look, now it become clear. It's growing and become clear, and due to increase in size as well as the evolution of the breast tissue. The breast tissue is getting more involuted. The
Yes.
lesions are there. So
Developing asymmetry. So
yes, I'll say develop. If you did not, okay, if you didn't see the previous, if you have seen it only here, we'll say this. You will describe it as.
I will describe it as a mass.
Excellent. A mass. Which mass? How you describe the mass?
This is this partially obscured.
Excellent. It's a partially obscured mass. And this is the lesion here on ultrasound. So
that is heterogeneous hyper and hypoechoic with
the heterogeneous circumscribed but rounded for biopsy, and it was a fibroadenoma. It's 4A, and it was a fibroadenoma that revealed. So in conclusion, absolute symmetry of the breast is rare, due in part to development variations, different in positioning and compression during the mammographic examination. Okay, and the asymmetries are unilateral discrete area of fibroglandular tissue density with no mirror image correlate in the opposite breast, not fulfilling the three-dimensional mass criteria according to Birat's. Asymmetry is a common finding seen on mammogram, but usually not cause for concern, represent benign superimposition of normal tissue, island of fibroglandular tissue. However, it is possible that the finding represent cancer. So, and the likelihood of cancer depending on the type of asymmetry. It possesses challenges of detection and interpretation. Why? Because lack of typical feature of cancer. Sometimes, not always the cancer presenting as a typical mass. It might just represent as an abnormal fibroglandular tissue density or asymmetry. And the frequent absence of ultrasound correlate for the developing asymmetries, which occur in up to a third of the patients. So ultrasound has no proven negative predictive value. if ultrasound is negative and the patient having developing asymmetry, we have to proceed for mammographic guided biopsy. And failure to biopsy these lesions may also lead to delay of breast cancer. To increase the breast cancer detection rate and provide many women with an opportunity for earlier cancer, so we have to, what happened? I don't know why it's cutting. Yes. Sorry. I don't know this. Okay. عارفة في فيروس في الكمبيوتر بتاعي، شايفة في كم سلايدز اتغيرت من الأول من البرزنتيشن مع ال Sorry for that. We can start from the beginning regarding the conclusion. We said that absolute symmetry of the breast is rare, due in part to developmental radiation. Due to developmental variations, difference in breast positioning and compression during examinations. And the asymmetries are unilateral discrete area of fibroglandular tissue density with no mirror image correlate in the opposite breast. And it is not fulfilling the criteria of a mass according to the PIRATS. And the asymmetry is a common finding from both screening and diagnostic mammography, but usually has no concern and representing only superimposition of normal tissue or island of fibroglandular tissue. However, a possible findings representing cancers and the likelihood depending on the type of asymmetry and possessing usually challenges of detection and interpretation. Why? Because the cancer not always typical, presenting as a mass or suspicious finding can just present as an asymmetry, and the frequent absence of ultrasound correlate approaching a third of the patients of developing asymmetry that make ultrasound has no proven negative predictive value, and lack of ultrasound correlate does not preclude mammographic guided biopsy. Failure to biopsy this lesion may lead also to delay in breast cancers. To increase the breast cancer detection rate and provide many women with opportunity of early detections of breast cancer, that need to follow the appropriate classification criteria suggested by PIRAT and detection of asymmetric finding and application of these lexicons, considering also these lexicons are fundamental, considering the clinical history, appropriately applying the ancillary imaging studies, and the radiologist should also be aware about the pitfalls and peers. And thank you very much for attention. Any questions?
Assalamu alaikum, Dr. Bob.
Walaikum assalam.
I am Heidi. Regarding to the slide, previous slide before the conclusion, could it be complicated cyst, ultrasound.
This one?
Yes, it could
No,
be.
this is soft tissue. This is a soft tissue. It is a soft tissue, and it was proven, biopsy proven fibroadenoma.
Oh, okay, thank you.
Oh, thanks.
Assalamu alaikum, Dr. Rabab.
Wa alaikum assalam.
Thank you for a nice lecture. I'd like to ask about hormone replacement therapy. When I have to do second mammogram after stop of hormone replacement therapy for the patient.